Welcome to the webinar, How to Optimize Your Implant Case During the Treatment Planning Phase. This lecture is being presented by Ibrahim Dukum, DDS, MS, FICD, and we will begin the webinar shortly. And now it is my pleasure to introduce Ibrahim Dukum, DDS, MS, FICD. Dr. Ibrahim Dukum is a professor of prosthodontics and the chair of the Department of Restorative Sciences at UNC Chapel Hill Adams School of Dentistry. He completed his DDS degree at the University of Jordan and earned his MS in prosthodontics from UNC Chapel Hill in 2008. He is a fellow of the International College of Dentists and the ADEA Leadership Institute. A published author, Dr. Dukum lectures nationally and internationally about all aspects of prosthodontics, aesthetics, and dental implant therapy. And now it is my pleasure to say, take it away, Dr. Dukum.
Thank you so much, Jessica. I appreciate the kind introduction. And good evening, everybody. Hope you have a great summer so far, and hope you have also fantastic rest of the summer and the year ahead. Thanks for joining us today to talk about some important aspects of how you can manage and optimize your case during treatment planning. So hopefully you have a very good and long-lasting outcome of success with dental implants. So I'm going to start moving my slides here. So first, a couple of things to disclose. I just have to disclose that there is no actually support for this lecture. Beyond that, I'm receiving an honorarium from National Dentix Lab for this presentation, but there is no further commercial support. The objectives that I would like to achieve today is I would like to help identify critical, important basic structures that routinely encountered in implant therapy and how we can work around these structures to achieve success. Understand some key biomechanical principles of dental implants and their planning, and leverage different implant designs to optimize aesthetics and treatment planning. But to achieve a successful implant treatment, it's all about the health of the tissue surrounding the dental implants. You would like to achieve good aesthetics, good function, and you want that to be maintained over time with very, very little complication. And it's a combination of multiple factors. Some of those are host factors, bone availability, the type of bone you're dealing with, how much attached gingiva you have. There are other factors that involved in the surgical procedures, the prosthetic procedures that you perform, and making sure that those are done with exceptional care to provide very good outcomes. And there are biomechanical factors related to things like occlusion, the type of implants you use, the width, the length of the implant, abutment designs, and prosthesis design. And if you think about it, couple of those elements are under our control, the biomechanical features and probably the surgical procedures. And so that's what we try to control and optimize during the implant planning phase, considering and appreciating and respecting what the biological factors that the patient presents with, and sometimes trying to enhance that through various adjunctive procedures that can be performed. But diagnosis and treatment planning related to single implants, fixed partial dentures, even full arch cases, it's retained by dental implants require a very good knowledge and clear understanding of where you're heading with the case. So planning is very, very, very important in our phase. And unfortunately, some don't plan ahead, don't plan for complications, don't plan for results that, that we would like for them to last for a long time. And that's sometimes when problems start to occur. So planning is very, very important part of dental implant therapy. Some of the important guidelines for diagnosis and treatment planning when it comes to dental implants, important to look at biomechanical guidelines and how that relates to your patient and how can you optimize the features of the therapy, the size of the implant, the type of the implant, the location of the implant, number of implants, spacing, how many implants you need per segment. Does that differ between an anterior case versus a posterior case? Some of the bioaesthetic guidelines to achieve or maintain aesthetics. Do you have implant location problems, particularly with adjacent structures and vital structures? And again, planning implant placement by very good communication between the restorative dentist, the surgical dentist, unless you're doing both, to achieve very, very good outcomes. Um, but implant biomechanics is a very, very crucial factor when it comes to dental implant therapy. So things that are very important to decide and plan ahead is width and the length of the implant that you would like to use, the prosthetic design even before starting. Is it better to have splendid or non-splendid implants, depending on the type of the implants and the number of implants you're placing, the number and distribution of implants per segment, um, implant connection, abutment prosthesis design, loading protocol. Are you going to load these immediately? Are you going to do them in early stages or conventional loading? And things like crown to implant ratio, and does that affect the outcome of the treatment? But if you start thinking about posterior implants, some of the challenges we have, whether it's in the maxillary arch or the mandibular arch, is proximity of vital structures. Have the maxillary sinus in the maxillary arch, and we have the inferior alveolar nerve in the mandibular arch. And it's very, very important that we, consider and appreciate uh, the proximity of these structures to where the implants are placed and how we can plan and work around them. Obviously, you want to stay at least about a couple millimeters away from the inferior alveolar nerve. For the maxillary sinus, depending on how much bone you have beneath the sinus, it can determine the type of placement that you will have. Do you have to do an osteotomy sinus lift? Do you need to do a lateral window sinus lift procedure? Can you place the implant and do the sinus lift at the same time, or do you have to do that separately? Also, it can determine the length of the implant that you would like to place. And in a lot of situations, particularly with certain consideration in which sinus grafting procedures cannot be considered, the use of short implants. And how does that relate to long-term success and function? But generally, we may have height limitation when it comes to posterior segment. If you compare that to the anterior segment, it's actually an opposite problem. Generally, we have good bone height, but sometimes we can run out of space horizontally. We may have that problem between for placing single implants between interradicular space or for fascial dimension of bone. So we have a width limitation, which can be amenable for the use of narrow implants. And if you think about the occlusal stress, well, there are higher occlusal stress in the posterior segment than what you have in the anterior segment. Aesthetics is much more important anteriorly than posteriorly. So we have to keep that in mind as we start thinking about our planning case for dental implants. So posterior implants, again, can we use short implants? How does that affect the outcome? What's the ideal implant height that we would like to have? How does that affect the distribution, the number of implants that we would like to place to achieve very good functional outcome long term? And how does that affect also the design of the restoration, going from cement retained to screw retained? Obviously, screw retained would be preferable because it gives you a true retrievability of the prosthesis that you can manage complications down the road if it's needed. So definition of short implants, if that needs to be utilized in your treatment or rehabilitation, it's anything less than 10 millimeter. And that can be used in cases where we have reduced bone height, proximity to vital structures, particularly inferior alveolar nerve and the maxillary sinus, as we just discussed. The bone is a load-bearing structure, so we have to remember that. Your whole body is supported by the skeleton, by bone. That's how we walk, we run all the time. And the same thing happens in the arches and the bone in the arches. So they can be loaded and they can be loaded successfully. The occlusal force is exerted onto the implants, transferred to the surrounding bone via the bone implant interface. That's a very, very crucial element that we have to think about while we're planning dental implants. Where's the interface of the implant with the abutment? Um, how wide that interface is, where it should be located, and how does that relate to the number of teeth that we are replacing. But when the implant is loaded, the majority of the shear forces of the occlusion will be distributed on the first few threads of the implant towards the top of the implant. So Therefore, once the minimum length of implant is osseointegrated, implant diameter becomes a much, much more important factor than actually implant length. So quite frankly, both are important. It's important to have a good implant width and a good implant length to achieve success. But which one is more important, particularly in the posterior segment? Implant width becomes much, much more important with the fact of how loading of dental implants, and because of the implant being integrated in the bone, functioning almost like an ankylosed tooth. So most of the stress is going to be around the top of the implant. So it's very, very important to have a wide base. So place the implant, place the abutment, you restore the tooth. Now we have transfer of the forces to the cervical area of the implant, and that part works more than the apical part for load distribution. So we can see a case like this where we have a short implant, but a wide implant supporting a molar, and can be very, very successful over time, even sometimes with no bone loss if everything was done properly. And how does that transfer to practice? Is again using the widest implant in the posterior segment to support the tooth that you would like to have. And in the molar region, you would like something around, probably 5 to 6 millimeter of implants. That would be ideal in that case. Premolar area, you want something around the 4 to 4.5 millimeter range. And as you move to the anterior segment, that's when you start utilizing narrow implants. Use of narrow implants in the posterior segment generally is not preferred. And if you have no other option, then maybe you need to maximize the number of implants and consider splinting, which is something that we'll discuss a little bit later. But increasing the prosthetic base, that's going to result in better distribution of the occlusal load and better stability of the implant components, resulting in less complication. And here's a systematic review that actually looked at the prognosis of short implants, again, less than 10 millimeter, placed in partially edentulous patients. This meta-analysis looks at 29 studies. They evaluated 2,611 short implants, and that implant length was anywhere between 5 millimeter to 9.5 millimeter, again, less than 10. And here's the survival rate that's found per implant length. Obviously, the least rate was at 5 millimeter. That's was 93%, and those at about 2 years of function. That number increased to about 97% by increasing the length from just 5 to 6 millimeter. And from there, it kept increasing to 9.5 millimeter implant length. The survival rate was 98.6%. So the biggest difference was between 5 to 6 millimeter. And notice here, when you go above 8, the survival rate is drastically much, much higher. So the largest difference, again, 5 to 6 millimeters. So probably placing anything less than 6 millimeters, particularly in the posterior segment, probably is not recommended. But also that has to relate of what's the implant width. And anything less than, again, 4 millimeters should not be considered, and preferably something that is wider. Here's another systematic review that looks at extra short implant, less than 7 millimeters, and narrow implants, less than 3.5 millimeter, looking at their survival. And both will have a very high satisfactory survival rate, about 95%, with very minimal marginal resorption, 0.5 millimeter or less in the first 3 years. So implant length less than 7 millimeter in the maxilla and less than 0.5 millimeter in the mandible were generally successful, but of course you'll get better success with longer implants. However, with implants with diameter less than 3.3 millimeter, the failure rate definitely increased. Those implants should only be utilized in the anterior segment and should be utilized, quite frankly, for even smaller teeth, something like mandibular central lateral incisor, maxillary lateral incisor, for example. Here's another study that looked at 15-year follow-up of short dental implants. And short dental implants, 8.5 millimeter or shorter, the primary outcome was looking at the survival rate and the marginal bone loss, and the mean follow-up time, 15 years. So that's a little bit longer term data that we're looking at. They looked at 75 implants, 30 in the maxilla, 45 in the mandible, and they found that implant position did not really significantly affect survival, meaning posterior versus anterior. Survival rate was about 93% after 15 years, which is pretty good, but marginal bone loss was more in the maxilla than the mandible. So the maxilla is at higher risk of failure and bone loss than mandibular implant. But what complications we're looking at? We're looking at biological complications such as implant failure, bone loss. We're looking at also some mechanical complications, things like screw loosening, screw fractures, abutment fractures, restoration due bonding, and ceramic fractures. These will depend on obviously other factor than the size of the implant, but the type of the connection, the width and the length of the implant, and their ability to support the prosthesis affect a lot of these features, resulting in minimal screw fractures or screw loosening and even abutment fracture, if you will. Prosthesis complications, that's something that is easier to deal with because it may require replacing of the superstructure. Problems with the implant connection or the implant itself, that's harder to deal with. That may result even in the loss of the dental implants. But you have to ask you the questions. Well, if I'm replacing multiple teeth, should I splint or not splint the implants? And certainly there are advantages of both approaches. But what you have to consider is, well, what's the size of the implant I'm placing? What's the height? What's the width? How much leverage is put on that implant? So if you look at this example here, these are implants with almost implant to crown ratio of 1 to 1 or worse. So there's so much leverage around the implant. You're going to achieve much better success, probably splinting those implants together than leaving as individual implants and dealing with the complications similar to what you see here. Also, what's the prosthesis design? Those were restored with a titanium tie base, resulting in a very, very narrow uh, implant interface, putting more stress on the cervical area, and here's the outcome. Now, how this was restored, if you want to even keep them as unsplinted implants for flossing, for cleaning, for hygiene, uh, go with a custom abutment, go with a wider base that's going to minimize the stress at the connection. We just completed a master thesis, and hopefully we'll have soon a publication about that where we compared screw-mounted restoration being made on anatomically designed custom abutment versus tie bases. And we did an finite element analysis that showed actually the amount of stress will be reduced by using a wider base because it distributes the load more preferably around the dental implants, resulting in less implant level complications or connection level complications versus prosthesis level complications. And here's an example. You have two implants. One of them is a little bit shorter. The decision was made here not to do a sinus lift, but rather go with the shorter implants and splint both those implants with a wider base, and resulting in a very solid biomechanical concept here for this patient that can result in a very long-term success. Obviously, if you have a complication that may happen here, well, it affects that whole segment and might result in a bigger problem for you. So you have to consider the restoration design. Is that cement retained? Is that screw retained? This is a cement retained prosthesis, but you can probably cement it for long-term provisional if a complication happens that you can deal with it effectively. But you have to consider the biomechanics, and you have to consider also how you manage any complications down the road. So from force distribution or the occlusal forces, I mentioned earlier, if you have to utilize narrower implants, smaller implants, you probably have to consider splinting, similar to what you see in this case. So in the posterior segment, you probably try to over-engineer by adding more implants. It makes it easier to manage. If you lose one implant, still the prosthesis can function for the patient. As a general rule of thumb, you try to minimize the cantilever design for the implants and minimize the cantilever length. And if you have a choice whether to have a mesial cantilever versus a distal cantilever, always mesial cantilever works better. And you start to consider wider diameter implants and the staggering of implants by cross-arch stabilization, which results in, again, better success, better preservation of bone around the dental implants. So why do we splint implant? Consider that the rotational axes around the implant in which the prosthesis exerts leverage and stress around the implant. That's happen in multiple axes. And by splinting the implants, not only sometimes splinting implants, but having one implant being off axis of the other, result in minimizing of those rotational forces on the implant interface, resulting in a better success over time on the dental implants. So if you think about some of the advantages of why implants can be considered or can be splinted in the posterior segment, prosthetic, again, force distribution, resulting in minimizing screw loosening or implant fracture. It's easier, particularly from less interproximal contacts to manage by the lab or by you at the delivery appointment. And it may allow you use the less number of implants, particularly utilizing proper size and number of pontics. There are biological advantages, and that has to be with implant size and diameter and length, meaning if you cannot achieve the ideal diameter and length, now considering distributing the forces among multiple implants can allow you to use smaller implants. Implant numbers, again, you may use less number of implants, particularly with proper size and position of the implant and pontics. And it's going to result in more implant stability over time, particularly if cross-arch stabilization is utilized. Now, so what's the ideal ratio of the number of implants to the number of teeth you are replacing? Ideally, the best is you're replacing one tooth for one implant, similar to what you see here. But that's sometimes an overkill. Sometimes, you don't have the bone structure there. Obviously, there are financial limitations. But if I can place, good size implants, lengthwise, widthwise, I can actually eliminate and stagger the segment and consider the pontic. But I shouldn't go more than every segment more than the width of that implant. Meaning if I have two implants, I probably can skip one segment and substitute that with a pontic. So posteriorly, we'd like to limit the number of pontics to one pontic, a maximum of two, if you will. Anteriorly, we can have more pontics, like to limit them to two if possible for certain type of patients, particularly the one that exerts higher occlusal forces, proxers, clinchers. But in the right type of patient, you can even consider more than two pontics, similar to what you see in this example. But this is also helped by cross-arch stabilization going right to left, which has a major impact on dental implants. The disadvantages of splinting teeth or splinting implants together is fabrication, because you would like these prostheses always to fit passively. And that sometimes can be challenging. You want to make sure that your impression is accurate, your cast is verified. And nowadays, with way we manufacture dental restorations, particularly with milling and printing, this process come easier than the traditional casting, where casting shrinkage of the substructure was a major limiting factor for achieving passive fit. Jaw flexure, particularly in the mandible, is a major concern. Retrievability on the implant, and here the need to have a screw retained versus cemented retained restoration, and hygiene, because you cannot floss. It's much harder to clean. Are you going to move those prostheses over time and maintain them with hygiene appointments, place them back? And then if you do that, then you have to think about how many times I can do it before replacing screws, for example. So those are all considerations that have to be considered during the treatment planning phase. Another factor is implant angulation. So a lot of time we angle implants so we can maximize the implant to bone contact, but also avoid vital structures, increasing anterior posterior spread, particularly for arch restoration, similar to what you see here in the all on six protocols. But again, bone does not care about the angulation of implants. It acts differently than the teeth. Ideally, you would like the forces to be vertical with the implant for better bone distribution. But if you have to angle the implant because they are ankylosing the bone, as long as you manage the occlusion properly, that should not compromise the implant long term. Another factor is crown to implant ratio. And we discussed the use of short implants and how that sometimes can be something that's very, very beneficial to us. However, you have to consider the length of the crown that you're replacing and what's acceptable from crown to implant ratio. The rules that we have for teeth doesn't apply for implants. Implants can be more forgiving when it comes to crown to implant ratio, meaning you can have a longer tooth on a shorter implant and still achieve a successful outcome. So normally after the extraction of the teeth, we have an optimization of the sinuses, and that leaves us with a very, very minimal amount of bone. Luckily, we can do sinus graft and place implants, but generally those will be shorter implant than we would like to have, and will have longer teeth because of the recession and because of the bone loss in that area. However, from clinical outcome standpoint, increasing the crown to implant ratio seem to be directly to increase marginal bone loss in some areas, but does not represent a biomechanical risk factor, meaning we have to be less concerned about crown to implant ratio versus that of teeth. However, I can tell you that if you're using short implants or narrow implants, again, considering using more implants and splinting those implants together should be a consideration, should be something that you have to consider during treatment planning. So let's see an example of the utilization of short implant and posterior rehabilitation and how is that managed considering the prosthesis design, the number of implant placed. So here's a patient. This patient actually came and saw me. She was actually from, if I remember correctly, Naples, Florida. This is probably was done at least 12 years ago. And she was struggling with a partial denture with a distal extensions, like what you see there. And she would like to have dental implants. And at the time when we just did a panoramic radiograph, looked at it, did some measurement, and clearly she's lacking bone height. That's both in the maxilla and the mandible. Obviously, better diagnosis can be done with a CBCT. And you can see here, not only that we have a problem with the bone height, but there is a lingual concavity that can be even an additional limiting factor for this patient. So you can see here in tooth number 30 area, if I want to stay about a couple millimeters away from the inferior alveolar nerve, I'll have about 7.4 millimeter of bone. Have a little bit more bone, number 28 area. Look at number 29, there's only another 7 millimeter of bone, and we have the anterior, the mental foramen and the anterior loop of the nerve. So can we still have dental implants? Yeah, we have 6 millimeter implants. We can place those, but would I consider an FPD with Pontic? Not for this patient. I'll probably try to maximize the number of implant by trying to over-engineer. Here's just looking at other sections of the CBCT and appreciating the lack of bone availability here. We have less issue with bone width in this case, but we have problem with bone height. So we planned 3 implants on each side of the mandible, 2 implants in the maxilla. The implants in the mandible, because of the size, we have 2 6 millimeter implant. The anterior was an 11 millimeter implant. We splinted all 3 together. So those implants will be splinted. If that posterior implant was longer, would I consider 2 implants and connect those with an FPD? Absolutely. Not for this size of implant, this height of the implant. So here is a provisional restoration of the implant placement and integration. Again, at the time we fabricated this with sports fused to metal. Nowadays, I'll probably fabricate those with a monolithic zirconia with no problem. Here's the prosthesis and the prosthetic design. You try to minimize the occlusal surfaces. You try to manage the contact by minimizing the forces of the implant or the occlusal forces on the dental implants. And here's the completed case. Those were done with prefabricated abutments. This is an Astra case, direct abutment done at the time. Probably if I'm doing this today, I will be utilizing custom abutments that are digitally designed and fabricated. Here's the occlusal surface of the maxillary teeth. The maxillary teeth, because they were good size implants, good width, good height, were unsplinted, so the patient can maintain hygiene. For the mandibular implants, they were all splinted together. And here's the completed case. And we followed this patient over time, and she was doing very, very well. Now, One area of concern here, particularly with the maxillary implant, is the position of these implants relative to the crown. You would like those implants normally to be central, so you don't have an offset that goes either to the mesial or the distal. This will act almost like a cantilever of the implant, increasing the stress of the implant, and you may have higher risk of screw loosening, screw fracture, and I've seen even cases in some patients who are proxers or clinchers that you may have even implant fracture. So ideally, you would like the implant to be in the middle and have equidistance from both the mesial and the distal. Obviously here, implant positioning could have been done better, but you have to consider also some of the anatomical limitation we have with the sinus and the sinus lift procedure that we have to perform. Now, moving to the anterior implants, that's an area where, again, as we discussed earlier, we have width limitation. So sometimes it's ideal to use narrow implants. The advantage of narrow implants, you respect more the biology. You can stay away from adjacent teeth, away from vital structure. You can place implants in cases where you have bone resorption without the need for adjunctive procedure and still have good width of bone encasing the dental implants. At least you would like to have 1.5 millimeter of bone in all direction of that implants and also good zone of attached gingiva. And that can be achieved with narrow dental implants. Now, we're not talking about mini implants here. We're talking about implants that are around 3 millimeter in diameter. Anything that's less than 3.5 millimeter, consider a narrow diameter implant. And that's what we can consider here, particularly for teeth like lateral incisors, similar to what we see in this example. For narrow diameter implants, anything that's less than 3.5 millimeter. Some of the potential benefits of these reduced implants, it results in better maintenance of peri-implant tissue because it's going to provide more space for the biology to work around dental implants. You can give you better chance of maintaining bone and maintaining things like interproximal papilla, like what you see here, to achieving very good aesthetic outcome. Again, aesthetics in the anterior segment is very, very, very important, very, very crucial for success. Um, it will result in less need for bone augmentation, less risk of damage to the adjacent structures. So here's an example where actually we're extracting 3 teeth because of periodontal disease, placing 3 implants immediately, and the use of narrow implants allow us to, in this case, place 3 implants while still have a good distance between these 2 implants to respect biology, having interproximal papilla, because again, adjacent implants, as we will discuss later, is a little bit challenging, particularly in the anterior segment from aesthetic standpoint, while maintaining enough bone, enough structure of the soft tissue between the implants. So narrow diameter implants in the anterior region, this is a meta-analysis that looks at their survival and success. They looked at 21 studies in which they have 892 implants in 736 patients. They followed these patients from a year to 14 years with a mean about 40 months. They had only 16 failures in which they have implant loss. So the survival rate and marginal bone loss were comparable to that of regular size implants. So definitely something that you have to consider in the anterior segment while respecting the biology, while having more bone, particularly that we know from evidence now that bone remodeling is going to continue throughout life, and the facial plate of bone can resorb over time. So maintaining a more width of bone, particularly in the facial of the anterior segment, can result in better aesthetic and bioaesthetic outcomes long term. Here's another study that looked at the overall 3-year combined survival rate of narrow diameter implants was about 98.7%, and regular diameter implants was 98.8%. Again, not statistically significant difference, and narrow diameter implants can be very, very successful in the anterior segment. But how much space, even for 3 millimeter implants, we need? When you do your evaluation, you have to look for about 6 millimeter of space or dimensions in all different directions. You need about 6 millimeter interradicular space, 6 millimeter of bone faciolingually, and about 6 millimeter of interocclusal distance. So this will allow you to place something like 3 millimeter implants, similar to what you see in this picture, without the need for bone augmentation, which was needed in this case that I'll present to you in a minute. Um, so that's called the 6 millimeter rule. This is a publication by my mentor, Dr. Lyndon Cooper, with one of my dear colleagues, Dr. Pinhari from Toronto. Uh, so it's the 6 millimeter rule for uh, single tooth implants in the anterior segment. If you have anything less than that, um, you know, you may consider augmentation because you would like to stay about 1.5 millimeter from adjacent teeth, and you would like to have the implant surrounded by 1.5 millimeter of bone in all different directions. So placing 3 millimeter implants will allow you to respect and achieve these outcomes. Something that's very, very important for aesthetic zone planning is you have to consider the location of the implant, the angulation of the implant, and the depth of the implant placement. You would like your implant to be roughly centered and coming out of the palatal side so you can allow you for a screw retained restoration without affecting the aesthetic of the patient. You would like the implant to be placed at least 1 to 1.5 millimeter from adjacent teeth. You would like the implants to, if you are placing more than one implant, the distance between the two implants to be a minimum of 3 millimeter. And you would like your implant to be about 2 millimeter lingual to the CEJ or the gingival zenith of the prospective restoration. This way, it will allow you to, have a nice emergence profile, but also at the same time have good health of the connective tissue and the bone. Obviously, the bone sets the tone here, although the tissue is the issue. But it's all related to the bone, so we would like to maintain enough amount of bone around those dental implants. The angulation sometimes, it's particularly with cases that you have highly resorbed bone, you may have to come out from a facial direction. And in that case, you have to use custom abutments. You can use some of the available technologies to us, like angulated screw axis or angulated screw channels. But ideally, we'd like the screw axis to come through the lingual side of the implant. As far as the depth of the placement, we spoke that we would like to have the implant about 2 millimeter palatal of the gingival zenith, and would like to that implant platform to be at least 3 millimeter from again the gingival zenith to allow for a good emergence profile. If it's a little bit deeper, like 4 millimeter, that works great. You don't want the implant to be placed so deep, and you don't want the implant to be shallow. And shallow implants can result in huge problems with emergence profile. And there is now strong evidence to show that that may result actually in hygiene problems, but also may lead to implant mucositis and periimplantitis and bone loss later on. But let's see a case where this was consideration for treatment planning. So this is Emily. Emily is a patient that I also treated probably about 12 years ago. And she came in, she was 21 years old at the time, and she was so excited because finally she would replace her congenitally missing lateral incisors. She has been through multiple phases of resin bonded prosthetics that were either debonding or fracturing. She did orthodontic treatment, have bonded pontics on her retainer, and that's what she presented with. And at the time, she came with her mom, and we were planning for dental implants. Took just a couple PAs, and was like, you know what, Emily, maybe it's not time yet. We don't have enough space, particularly for tooth number 7 interradicularly. So I have to put you back in orthodontics for about 6 months just to align these teeth better and open the space for dental implants. Obviously, she was disappointed at the time, but understood the need for this orthodontic treatment. So this orthodontic treatment was done by my dear colleague, Dr. Wen, our graduate program director of orthodontics now. And you can see that we achieved better alignment of the teeth and opened the space that now, again, we have that 6 millimeter of space that we would like to place the implant in the ideal location, mesodistally, facial-lingually. So planning diagnostic wax up so I can see where I'm going with the case before I start. It's prosthetic driven planning and implant placement. Now I can know where the gingival zenith of the prospective restoration. And at the time I can give my surgeon, in this case, I did not place the implants, but Dr. Nadine Brodala placed those implants, and we will go about 2 millimeter palatal to the gingival zenith, about 3 millimeter in depth, and place the implant where actually it needs to be from a prosthetic standpoint. But notice here, Emily was actually lacking bone width in facial-lingual dimensions. Again, these teeth are congenitally missing. So we can do bone augmentation done at the same time of the implant placement and follow a two-stage protocol for this patient. And after the implant space placement with simultaneous guided bone regeneration is a very, very predictable procedure. And after second stage, we actually, to achieve better aesthetic outcome and sculpture the soft tissue, manage the soft tissue very, very nicely, we did that with provisional restorations. And afterwards, fabricated, computer-aided design, fully anatomic abutments designed for Emily. Those were titanium Atlantis abutment from Dentsply, Astra at the time, gold shaded. So we can maintain implant to implant contact. I mean, titanium to titanium contact inside the interface. Um, but at the same time achieve a very nice aesthetic outcome, place the margins exactly where we want them to be, and have a very nice emergence profile. So these are the restorations. There were EMAX, lithium disilicate, crowns fabricated by Absolute Dental Lab in Durham with Atlantis gold shaded titanium abutments. And so Emily came in, and finally, we can place these abutments successfully supporting the soft tissue, and she can have very nice crown restorations that done beautifully. And finally, Emily, can have teeth that are definitive, that are permanent for her. She doesn't have to remove them, and she can have finally smile. She was going to college at the time, and this was again life-changing for her. But the key here is respecting the biology. Biology always wins. And sometimes you have to go the extra mile by planning, by doing orthodontic treatment, by doing the bone augmentation, so you can have a long lasting result. I still communicate with Emily 12 years later, and these implants are still successful and functioning and aesthetic for her. This is another case. This is Jane. And Jane was involved in a car accident. This was one of the first cases where actually we did bone augmentation using also BMP2 as a growth factor to help with bone augmentation. She has a paper thin ridge, and she's tired of removable appliances. She would like to consider dental implants. So I did this case with Dr. Glenn Reside, one of our maxillofacial surgeons, and you can appreciate how thin the bone here. But we have good bone height, and that's something that we can graft to. And we used a particular bone with BMP with tenting screws to graft that area. And now we have a little bit more bone width to place implants, but those are going to be narrow implants. Even though it's in the anterior segment, when you have a case like this with the size of prosthesis, remember the discussion about the implant to crown or crown to implant ratio here. It's going to be significant because of the amount of bone loss that Jane has. So here actually we maximize the number of implants that we're placing. So we placed 5 implants to replace 7 teeth, and certainly those will be splinted together. And so that's what we did here. That's just showing her interim prosthesis that we're using to replace her teeth. And then we fabricated, again, custom CAD design abutments. And this is a large span implant FBD with pink ceramic. But notice here that actually we're still thinking about hygiene and cleaning. This is what comes back from the lab. Notice here we have a ridge lap here, very beautifully done. But again, you put this in and how the patient is going to clean around this, and that's why we modified that to create more access for hygiene so she can maintain those implants long term. So you have to design for the biomechanics, you have to plan for hygiene, you have to plan for problems down the road and how the patient can maintain these prosthetics. Jane ended losing another tooth and had another implant in the first premolar site there. But the question here, how many implants do we need? Certainly not what you see in these radiographs. Um, but is there different guidelines when it comes to the anterior segment versus the posterior segments? And certainly we have to think about nature. What are we trying to recreate? And this is the anterior segment of the teeth. Think about the pink aesthetic. Think about the teeth. Think about the transition between those two. We would like to maintain interdental papilla. We would like to have a nice architecture of the teeth and nice platform to support that. And generally, it's very hard to achieve that by having adjacent implants, particularly something that's very close to each other, because that can result in bone loss between the dental implants. So we can actually achieve that by placing less number of implants and the utilization of Pontics following the guideline that we just discussed. Placing the implants about 3 millimeter deep, 2 millimeters to the palatal, use the right size of implants. So in this case, probably wider implants for the central incisor or the canine, maybe narrower implant for the lateral incisor if that's the case, and utilizing Pontics, particularly ovate Pontics in the anterior segment with the proper placement can result in very good outcomes. So when it comes to meeting the aesthetic demands in the anterior segment, sometimes less is more, okay? Less number of implants, utilizing Pontics, not large number of Pontics, one or two can achieve very good outcome. The two implants can be used to support 3 to 4 unit prosthesis, depends on its location and the magnitude of occlusal forces. So that's a very, very good consideration for the anterior segment. Again, try to avoid adjacent implants because according to what we know from the literature, if I want to maintain interdental papilla, the distance between the contact point to the bone, that should be about less than 5 millimeters. If we have that, we can have interdental papilla 100% of the time, meaning I have to preserve this bone if it exists, and having implants very close to each other can result in bone resorption here, resulting in black triangle, resulting in bone loss of the dental implants, which we try to avoid. Also, if you consider how much bone loss by considering the distance between implants, if you have less than 3 millimeter, you're going to have about 1 millimeter of inter-implant or 1 millimeter of bone loss with an inter-implant distance less than 3 millimeter. If you increase that to 3 millimeter or more, look at the amount of bone loss. It's more, it drops by more than half. So about 0.4, 45 millimeter, this according to Tarno. So how much distance we need between adjacent implants? A minimum of 3 millimeter. With platform switching, that can be a little bit less, but still try to respect that 3 millimeter distance. We achieve very good outcome because it can be very, very challenging. Similar to what you see in this case, two implants next to each other, and you appreciate that we have a little bit of bone loss between the implants, and now we have a longer contact and not an ideal interdental papilla. So how can you overcome that? Again, use less number of implants, utilizing Pontics, utilizing even cantilever, like what you see in this case where the implant was placed in the canine position and we have a cantilever over lateral incisor. I like to maintain, to keep those only for the maxillary lateral incisor, mandibular, central, or lateral incisor, but you can achieve very, very good outcome with these patients. And if you look at the 5 to 10 year survival rate of these prostheses, it's about 94% and drops to about 89% after 10 years. That's a very good success rate, almost identical to that of single tooth implants. So it can be a very, very successful treatment for the patient. Now, if we think about the posterior segment, higher occlusal forces, generally we have height problems, less width problems. So it means we're going to use probably more short implants. So we try to at least use 3 millimeter, 3 implants recommended with there is needed for great support. 2 millimeters with a minimum of one Pontic or a maximum of one Pontic, excuse me, in any segment if we want to just use two implants and connect them in an FPD fashion. So 3 or more implants may permit even if we lose an implant, that this prosthetic or prosthesis can be very, very functional. Number of implants related to its length, 10 millimeter or less result in 10% average implant loss, so a little bit more than that of shorter implants. If they are more than 10 millimeter, less 3% average bone loss. So again, implant length in this case is important, but most important how the length related to the width based on the previous discussion we have. And when only can use short implants, you try to over-engineer by maximizing the number of implants. Not only that, but also consider splinting implant together. And even when you are splinting, have maybe one implant being slightly off axis of the other two, because that's going to help with minimizing forces and stress at the implant interface. So from functional engineering, you try to consider increasing number of the implants when the diameter of the implants is reduced, when the length is reduced, considering also the occlusal scheme of the prosthesis. But in the posterior segment, we always have to err on the side of over engineering because, again, we'd like to maintain functionality for a long time. So we have to evaluate the occlusal schemes, minimize cantilevers to pretty much a one cantilever that's almost the same distance or the same width as the implant platform that we are using. And if we can place that or keep the cantilever in the mesial side, that works then if you have it on the distal aspect. But sometimes you may have to consider those distal cantilevers. And if you do, notice we try to minimize the occlusal surface and the occlusal table of these prostheses. So it's always better to over-engineer in the posterior segment. So here is an example. This is a patient that we did full mouth reconstruction for. He has long span FPDs that were functioning for about 15 years, starts to break down, work, and those were long span FPDs. And he would like to consider just rehabilitation with uh, short span. So we decided to actually place dental implants in the post-posterior mandibular segment and the maxillary right segment. These implants, because of the amount of bone loss that he has over time, were only about 4 millimeter width. They were long implants, 9 to 11 millimeters. So we placed 3 implants for the mandibular left segment, 2 implants in the mandibular right segment, and 3 implants in the maxillary uh, left with the sinus left prosthesis, and then decided to splint those together. So here is the picture of the um, tooth preparation. The implant abutments, those were preferable abutments at the time. We were not using as much of the custom design abutments, but notice how these, we maximize and over-engineer the number of implants there. This is the insertion visit where the prosthetics were placed, and we can appreciate the occlusion for this patient. And again, we can achieve a very nice aesthetic outcome for the implants with cement retained restoration, beautifully done restoration for the patient. And here is the mandibular segment, obviously to stay away from the mental foramen and the anterior loop for the nerve. We had to place this implant slightly distally, so we utilized a cantilever. But again, it's a small cantilever and it's a mesial cantilever. Works very, very well. And now the patient has a very nice smile and very functional outcomes. Obviously, for these cases, always you need to have an occlusal guard for the patient to function with. But look at this. This patient was treated about 16 years ago. Here's his 15-year follow-up. No problems, no complications, whether it's on teeth or implants, almost no bone loss. Splinted implants, slightly off axis. These are cemented with provisional cementation, meaning, and they have been cemented with provisional cementation for over 15 years. And if I have to retrieve any one of those segments, probably not going to be easy to do, but it's possible. I can probably tap off this bridge to manage any complication. Luckily, touch wood, we had no problem with these patients because look at the platform. It is actually a narrow platform. So I cannot probably do this with single tooth implants and affect this outcome, meaning unsplinted implants, and expect this outcome over time. So would I like to have, unsplinted implants so the patient can maintain good hygiene? Sure. But you have to respect the biomechanics. You have to respect the biology of what the patient presents with as far as the amount of bone and how you would like to also manage proximity to vital structures. You have to consider sometimes the use of shortened dental arch, meaning you don't have to replace second molars all the time. You can, stop at a first molar, even a second premolar for certain patient. That still will allow them enough function and still allow us to use less number of implants, but also manage the occlusion very, very well and achieve very good aesthetic outcome. And again, appreciate vital structures and respect them, such as the inferior alveolar nerve and maxillary sinus. And here's a patient where actually we treated with 2 dental implants and ovate ponting in the posterior segment, stopping at the first molar and achieving exceptional aesthetic and functional outcome. You could appreciate that we have lack of interclusal space, which has also an effect on the depth of the placement and managing the soft tissue to achieve very good outcome. Here's another patient where actually we utilized the single implants with a mesial cantilever to replace anterior teeth, and again stopped at the second premolar. He still have some posterior teeth, but we did not feel the need of including a cantilever or distal cantilever in this case, which will put more torque forces on these implants, particularly with the size of these implants being around 4.2 millimeters. So again, you have to think about the biomechanics, the biology, and the long-term effect of that on the patient. And here's the completed case. And notice that these are done in screw-montable fashion for easier management of complication, having the prosthesis fully retrievable. So as I wrap up this, let's finish with some summary and conclusion, things to remember, particularly with optimizing and setting up your case for success. Less is more in the anterior segment. You can minimize the number of implants, you can utilize Pontex and achieve very good aesthetic outcome without compromising functionality, respecting the biology for the patient. When it comes to the posterior segment, more is more. You'd like to over-engineer, maximize the number of implants so you can be prepared more if complications happens, but also to have a more solid functional design for these prosthetics. Simple rules are needed that can help you optimize the results, similar to what we're presenting here, and improve the outcomes. And that's both whether you're experienced practitioner or novice practitioner. Simple rules always helps, and simple guidelines always helps. Develop decision protocols in an effort to improve quality and consistency for your treatment, for your planning for the patient. Short and narrow implants are very, very viable options that can be utilized with success if it's done properly. Narrow implants in the posterior segment, preserving more bone, more soft tissue, and achieving better aesthetic outcomes. Short implants, avoiding vital structures, but definitely thinking about that relation between the width and the length of the implant and the number of the implant and the prosthesis design, whether you splint or unsplint your dental implants. Biomechanically challenging clinical situations, although they are not necessarily associated with significantly higher implant thrust rate, but they have to be addressed with caution. Always consider maybe getting second opinions, consulting with your specialists or colleagues, and definitely take a very, very careful look at treatment planning. And again, use of narrow implants can generally reduce the cost of the treatment because it may require less adjunctive procedures, sinus lifts, bone augmentation, that has an effect on treatment time, but also the patient, not necessarily the patient morbidity, but the implant site morbidity. So sorry for this is a mistake here that should be corrected. So I apologize for that. But as of that, I conclude this presentation.